So welcome everybody to today's session, which is presented on behalf of Society's Clinical Practice Committee. I am Valentina Robila, and I'm a cytopathologist at Virginia Commonwealth University. It is my pleasure to introduce the speakers and today's, we think, timely and interesting topic, a catalyst for future cytologists, getting them there. We hope we can answer your questions, comments. Please submit them via the chat. And we'll have a brief discussion midway to the presentation, and then we'll address the rest of the questions at the end of the presentation. Just a few words of introduction. We all acknowledge that the field of pathology is undergoing transformative and exciting times. They are driven by advances in molecular diagnosis, informatics, and an increased focus on personalized medicine. However, to meet these advances, laboratories in general, and we have to acknowledge that pathologists come under significant pressure as we are encountering increased complexity of specimens, of ancillary testing, and an overall need for broader knowledge base to be able to incorporate the clinical information and report these complex results. As a consequence, for a number of years now, it has been postulated that the time has come for implementation of a new career track. One term, Advanced Practitioner in Anatomic Pathology, was proposed by the Mayo Clinic group. Other iterations of the term also exist, but more importantly, the consensus of the community, of pathology community, is that cytotechnologists are prime candidates for training and expanding their already expertise and skills to meet the current needs. A few examples: at various institutions across the country, cytotechnologists already independently perform rapid on-site evaluations, participate in screening of cell blocks, core needle biopsies, and even some of the surgical biopsies, such as prostate biopsy. They may be involved in interpretation of predictive and prognostic markers, such as proliferation index, breast biomarkers, and sometimes even quantitative tests such as PD-L1 that require certain threshold for clinical decisions. Another area of increased need for each laboratory is the selection of tissues for in-house or send-out molecular testing, and these tasks also can be performed by cytotechnologists, both for clinical use and increasingly probably also for research purposes. And finally, cytotechnologists have been essential for implementation of digital pathology and telepathology on various platforms. And the examples can go on. But as we continue to acknowledge these new roles and contributions by cytotechnologists, we also feel regulatory changes are needed to precisely define these advanced roles, to allow appropriate training to meet the competencies for the roles, and to follow with commensurate career-led recognition and reimbursement. With this in mind, our first speaker will present the experience on this process implementation at her institution. So please welcome Melissa Randolph, who is the manager of cytopathology operations at Indiana University Health System.
Thank you, Dr. Robila, and welcome to the community. Thanks for joining us today for this talk about our experience in this. And really what you're going to hear today is a discussion about some things that were born out of necessity, born out of a short staffing situation that we went through with our pathologists, born out of the idea that cytotechnologists are tremendous patient advocates, and also kind of things where we're converging on needing to come up with a career ladder for cytotechnologists as time goes on. When you think about the cytotechnology role as traditionally defined, there's limited opportunities for people to advance or to go onto management or things like that. What we're going to describe to you here today is really more about how to turn this into what project management looks like, what patient advocacy looks like, what filling practice gaps looks like. And so we're hoping that this spurs a lot of good questions from the group. I'd like to just begin and talk about the idea that what we're discussing today has a precedent. Nurse practitioner is a good way to look at, the symbologies between our two professions. In 1965, there was a demand for acute care that absolutely skyrocketed alongside a demand for the physician-led model. And because of this, because no one could keep up with this acute demand, there was a landmark publication that was written, and it was encouraging this prescribed shift towards practical learning and greater autonomy in the nursing community. And what we'd like to postulate to you is this idea that cytotechnologists, the pathology community, can kind of follow this model and do much the same thing. But it is going to require a paradigm shift, and it is going to require a lot of effort in terms of what management needs to do for the profession, a lot of effort in terms of what schools are doing to get the profession ready for this, and then the buy-in that's required of the cytotech community as these roles are defined. So today, my part of the discussion is really just to focus on what's the business case for this look like. What types of presentations can be made to your hospital administration, to your lab administration, to convince them that this is a good direction for everyone to go in? So we'll specifically talk about role definitions, what this does for cytotechs in terms of engagement and what benefits they derive from it. We'll talk about a few challenges, and then we'll talk about how we were actually successful in building a business case to convince our administration that this is our new direction. So when we think about the evolution of an employee, this is actually borrowed from a Forbes letter. In the past, and when we went to school, we were pretty much told as we were making our way into the lab, we're looking at a 9-to-5 job. We're looking at a time where you're going to spend a little bit of time in an office looking at a microscope, screening slides. If you're lucky, you get to go on FNAs and things like that. You may do a little bit of processing in the lab. But those times, through whatever innovative disruption healthcare has experienced, are really kind of going by the wayside. And what the future looks like for a younger generation of cytotechnologists are a more driven type of situation. Work doesn't have to occur between 9 to 5. Work doesn't have to occur in an office setting. Some of the collaborations that we're going to describe occur on your phone as you're traveling from place to place. So where the work is occurring is different. How the work is occurring is different. You know, we can use our phones, we can use different types of digital image analysis. We can work anywhere. Before, when we would talk about what a cytotech career was like, there was a very prescribed way of doing things. You would come to work, you would perform your screening, you would maybe get some feedback from pathologists, and it would be kind of limited in terms of what are you behind the scenes? What do you get to see? But what we're describing in today's society is more of customized work. The idea that we're talking about precision medicine on a daily basis necessitates us to understand that the inputs as well as the outcomes matter. So cytotechs are well poised to understand and affect and influence those outcomes. In today's world, we can share information very, very differently than we did before. It's instantaneous. As we share that information, that actually gives you the opportunity to become autonomous, become a leader in your own right. You don't necessarily have to step into management in your career to be a leader. And what these two ladies that are going to talk to you about today is definitely leadership in its own right. So when we think about the change and how our work is performed, you know, we have this really need to support that and to move forward because the pace of healthcare is necessitating us to reinvent ourselves. The driver is the patient outcome, and that's what we have to rise to. So the reason that any of this came about in our particular institution is because we were being challenged to come up with a career model that kept our cytotechs engaged and involved in the fields. And, you know, it's one of the worst things in the world when you're managing a department and you have people walk out the door And the reason they walk out the door is the idea that you just can't keep them. They're just not motivated, or they think the field is dying. And so what we really needed to do was shape the way that our cytotechs were engaged in what their career looked like. And as they become engaged, they really are able to kind of design the job the way they want. They are self-directed. They don't need a lot of direction from pathologists. That's the strength of what we've created in this profession. And as you become engaged, you then understand what autonomy, mastery, and purpose is. Our purpose is that we are here to serve patients. How do we do that? We gain mastery by lots and lots of experience, by doing our didactic learning modules, and then learning to collaborate. We now have the ability to have autonomy in our jobs. So we want to keep people in this burgeoning profession. It is not dying. We are in a position right now to totally reinvent it and to really redefine our roles. So when we think about role definitions, this is really important to lab administration and anybody that you're going to try to make a pitch that you need an innovative change. So we were challenged to come up with what does this role look like? What are the career ladders looking like? You need to define all of this. So we wanted to make sure that as we thought about how cytotechs can be used as pathologist extenders and any type of helping the pathology lab, that we are very, very specific about this. And, you know, hopefully with your administration, you do get to tie that to some kind of a salary increase. But I think as time goes on and people realize how much worth and value they provide to the lab and to the patients, that is satisfaction in and of itself. So it's not always about salary. Sometimes it's really about that idea that I have created something, I have helped someone, and that's what moves it forward. So our team in this facility consists of really 3 levels of cytotechnologists. We have a very, very high functioning team that has different levels of expertise. Our Cytotech 1 are cytotechs that are newly graduated or up to 3 years with laboratory work experience that encompasses really 3 years or less. So they really haven't hit that threshold where they can do CLIA-driven QC or anything like that, but they're learning. They're incorporating a lot of things into their daily work. They're meeting people, they're making connections, they're being ingrained in what the profession is like. The Cytotech 2 then starts to get to more of that level of mastery. We don't necessarily prescribe at 3 years that people are going to become Cytotech 2s. They have to be able to demonstrate a lot of other skills, and I have those on the next few slides. But we're recognizing that because you've been here a while and because you have experience and you've created these relationships, that you're going to be able to get to another level. And then finally, our lead cytotechnologist or Cytotech 3 are really doing practitioner level work. They are able to assimilate, incorporate lots of different types of information, anything from the medical record of patients to different types of outside reports to molecular reports. And they're able to look at all of this together and start to figure out if someone reached out to them, what could we provide to patients? What's within our capabilities? What perhaps has already been done that we might just be able to shed light on to our busy practitioners these days. So that is just what our team looks like. And then I have, on the next 3 slides, I actually have spelled out what our role definitions are. And I really don't want to spend a whole lot of time on this. People can go back and look at this later. But really what I want to point out here is this career ladder isn't just a progressive, I do this step, I do this step, I do this step. It's really shown to be very collaborative. So you're going to build on your experience as a CT1, and you're going to learn to mentor people, and you're going to learn to lead projects that are, you know, patient outcome driven. And then you're going to get to the point where you are functioning autonomously with pathologists and oncology nurses and navigators, where we trust you to be able to be the ones to, speak the language that they need to hear at the time when they need to hear it. So these role definitions are something that probably is of interest to people that are looking at this from a management perspective, but this will just give you an idea of, what's normal practice, what's baseline, and then what do we say is elevated practice. And so we have that for you to review. When we think about what we've been able to do since we've instituted these roles, we definitely are able to serve with growing benefits to our patients. The morphologic skill basis that we have allows us to also step into the idea of reviewing the core biopsies and reviewing smaller pinch biopsies or even large resections to use that morphology skill and try to assess what's tissue adequacy look like. So we've done that. Using confidence and gaining rapport and making those connections with people, we've been able to go directly back to radiologists and say, we know that this patient is actually here for a very different purpose than you think. And let's have a discussion about that and make sure that everyone gets what they need before this patient gets off the table. Those kinds of conversations occur at every level in our cytotech staff. And while it was a little bit hard to get over that hump at first, and speaking to a physician on that level, you realize that they are looking for that level of help from you. They are just as busy as what our pathologists are. Anything that you can do to help them make their job easier, they will welcome. And then finally, some of what we're going to describe, innovation and the idea that we can maybe think through things in more of a problem-solving type of way. We've been able to help a lot of patients not have to come back for additional biopsies because we can assess their tissue differently and maybe figure out maybe immunostains belong on this particular specimen. Maybe molecular would be better served on this specimen. So those are the types of skills that we are looking for and that we are wanting to share. So we want to build kind of a business model that demonstrates this value. And then what really kind of gets you over the hump is assigning a blue and a green dollar to it. Blue dollars are something that is related to salary. Green dollars are something that is related more to the idea of what types of supplies can the system save on, time, things like that. So just using basic assumptions here, when we think about a patient presenting for a procedure, and we think about all the staff that's involved in that happening, we're just going to assign a number of about $5,000 to that. And we're thinking about the time in the facility, the radiology equipment, the staff that's present, the supplies that are used, those really expensive core needles that everybody is wanting to use now and has promoted. So we think about that, and we think about what have we been able to do as cytotechs that have prevented those patients from having to come back and be rebiopsied. And when we put all that together, that is a massive number. And that is ultimately what we used to convince our administration that it is worth investing in our staff this way. And then because we were also facing really severe pathologist staffing restrictions, we were also able to show that it's worth it for the cytotechs to spend their time on things that pathologists traditionally have been charged with doing, can do it well, can maybe even do it a little bit better based on the amount of time that they can spend. And that is an additional salary savings for the system. So that was very, very convincing for our administration. So when we think about all of this together, what's the disruption? The disruption is that we have rapidly changing models of healthcare. We have a demand like we've not seen before. We have not enough staff over the last two things that have happened during COVID to really weather this. So we have to create the staff. We have to want to invest in people, and we want to try to make it known how exciting it is to be here right now. As we do that, and as we really work to prevent turnover, we know that we can now create more of a competitive cytotechnologist salary. You know, we're looking at other models that have gone before us, and we're able to say we can build our career ladder similar to this profession here. And not only does that help us attract our cytotechs, but it also really helps us retain them. We want to compete for the talent that we want here while we're enhancing the values of excellence and service and research and innovation. Because we've been able to attract the talent that we have made more innovative strides. And we really like seeing that. It's a synergy. It gets people excited. We're able to kind of share that with people in our enthusiasm. So what we're working to do and what we're presenting to the community is this idea of developing team members, cytotechnologists, cytologists, whatever you want to call us. We're pretty cool people, and we can fill gaps in what our pathologists are not able to do now and in the future. We can help them now. We can save them time now. We just need a little bit of investment from the pathologist to understand that it can be done and that it'll be of great benefit and value to you overall. So I'm going to pause here for a minute with Dr. Robila and see if anyone has any questions so far before we get into you guys hearing from the people that are on the ground doing this.
Thank you, Melissa. So this was a very eloquent presentation. So I'm going to have a question from a viewer, and then I have one of my own questions. So the question from the audience is, have you seen employee satisfaction increase when they are given ownership in a particular role? So I guess it's not the predicted, but what is your actual experience?
Have we seen their satisfaction? Yes. So we measure, as do a lot of different large organizations, what employee engagement looks like. And we definitely have parameters that are based on salary, but we have more parameters that are based on the idea that I feel like my work has purpose. I am driven by my work. I want to be a part of things and do projects. And just off the top of my head right now, in addition to the type of people that you're going to hear present today, I can think of 10 other projects that we have going that are cytotech driven, that are improvement based for pathologists or patients, and that really, you know, we're stepping back, we're getting out of the way, and we're letting them say, we see something that we could do better for patients here. You know, what would it take for us as an organization to support that? And it's that whole idea of even project management. You know, we didn't go thinking that any of this was possible working in a lab, but not only is it possible, it definitely builds an excitement. And maybe these two ladies would be able to speak to that, but I can see palpable changes in the time that we have invested in our cytotechs and what we've been able to get out of it as an organization.
Another question, kind of along the same line. Has there been, to your knowledge, any progress in developing a billable code for cytotechnologists performing rapid on-site evaluations?
Not to my knowledge. I know that that is brought up in just about every ASC meeting that I've attended. I know that there are people that know that we probably ought to lobby for that, but not to my knowledge that it's happened. We just do use a global code for the time and supplies that cytotechs spend on procedures, and it's definitely a pittance compared to what pathologists get. But here again, these two ladies are actually going to speak to why even spending that amount of money is valuable to the patient experience overall.
Thank you. And I have a question that goes back a little bit and talks about education for transitioning into these advanced roles. So what do you think that it's the most efficient or maybe currently the most accepted way of training? Should it be in-house training on specific skills that are needed for each individual practice? Or shall we think more of a master level type education that is provided by accredited cytotechnology schools.
We definitely need the cytotechnology schools to support the idea of understanding some of the technologies that we're currently being faced with. But as far as training for these roles, nothing accounts for experience. There's no amount of time in a master's program that is going to replace the amount of time that you use your eyes and you understand the morphology and you're encouraged to look at feedback mechanisms and things that you don't have access to in school. So I'm a big proponent for on-the-job training. And yes, it needs to be done in a prescribed way, but there's no reason that we can't work towards that as a society and maybe getting that down and sharing that with people.
And just a continuation on this topic. So how are you specifically dealing with salary for cytotechnologists that come as graduates from the master program? So do you go by experience or do they already get accepted at a little bit higher level?
So we haven't had anybody apply for our area in Indiana that has had a master's degree yet. I'm sure it's coming. However, as an organization, it doesn't necessarily change how we would hire or what we would accept in terms of them entering the workforce. I mean, bottom line, in a lot of different large organizations, they are going to be looking to reward expertise and experience over the idea that someone has a degree. So until something changes possibly in the reimbursement with cytotechs attending FNAs and how their time is spent, I don't know that it's going to really get attention of a place like ours. That's probably not what people want to hear, but it's the truth.
Thank you so much.
Okay.
So thank you everybody for submitting your questions. I think we were able to have some light on some important topics. So next I'm going to introduce our two new presenters, Jessica Vandyke and Leslie Huntsman, who are currently cytotechnologist level 2 at the Indiana University Health System.
Hey, thank you, Dr. So Leslie and I both remember when we started Cyto School 12 or 13 years ago, being told that this profession was going to die and that we should really choose something else. Back in the day, it was the liquid-based preparations and then the slide imagers and then the changes to ACOG screening recommendations. And now there's a lot of buzz around primary HPV screening and the vaccines. So I think that most cytotechnologists have always had this idea kind of that, adaptation and evolution were going to be necessary. And some of this has come about organically, just with medical advances. For example, I worked at a hospital where we did see a dip in our GYN numbers, but then we started doing a bunch of EUS procedures and the FNA numbers went way, way up. So, beyond these adjustments that involve just a shift in normal workload, there's really a space in our field, kind of like Melissa said, for us to expand beyond conventional roles and assume these more advanced roles. And this space represents a real need in pathology because we're not just freeing up pathologists' time. We're also able to fill gaps that generally go unfilled. And this results in a huge difference in turnaround time and cost savings. So Leslie and I are going to tell you about our experience coming here to IU Health and adopting these roles. And we'll try to cover what we do, what it took to get here, and what it was like for us to make this transition. You can see from our little mini bios here that we have really different backgrounds. The majority of my career, I was in a hospital experience or, had a traditional experience at a hospital, whereas Leslie came from a private lab setting. So we'll be able to give you two different perspectives here. And Leslie's going to chime in and talk about our workload transition.
As you can see in the first pie chart, that shows my background. I came from a private lab. I only screened image-guided paths. I went straight from school into the private lab and only screen PAPs. And then when I came to IU Health 3 years ago, I had to refresh all of my non-gen and FNA morphology. I had not looked at FNAs or non-gens for 8 years, and I had never even been on a rapid assessment out of school. So it was all just a big transition for me. It was really scary, but I was up for the challenge because I wanted to work. I needed something new. And then the second pie chart shows where Jessica came from, a more traditional hospital role where her focus was on PAP screening, non-gen FNA screening, and some rapid assessments. And then the last pie chart shows our workload here at IU Health. Not only are we doing non-gen PAP and FNA screening, but we've also taken on this more elevated role, and we spend about half of our time in this more complex, elevated ancillary type role. And Jessica will go into explaining that a little more.
Yeah, so like Leslie said, a lot of this supporting ancillary testing, it's kind of the first point that we have for these two ways that we deal in expanded roles here. And the second one deals with doing rapid assessments, and we'll kind of talk about that later. But for the first point, supporting ancillary testing, let me take you kind of through the level of complexity that we're dealing with here. So we'll receive an order and a case, and the order has varied. I mean, we get IHC, molecular, FISH, genomic sequencing requests. So we've got this vast list that we are familiar with. And our first step is to review the order, and that ideally would look like we would see if the test has already been completed. Was there a recent biopsy and it's already been done? Is it appropriate for the disease type? Is it a PD-L1 that's ordered on a breast cancer and we see it's not triple negative? Or maybe there's an order missing that's standard of care that we see has not been done. So any of these things would necessitate us contacting the ordering ND and kind of liaising with him or her to see if, there's a question there. Do we need to add something? Do we need to cancel something? Which we would then be able to do. So finally, we would be able to select the tumor on the slide or select a block. And another important thing to note here is that if it is inadequate, that we are definitely tasked with trying to determine if we can find something that is adequate. We have actually developed a cell transfer technique here at our lab where we're able to run a lot of immunos on a cytology smear. So that's always an option. Or, we look into all the previous pathology to see if there might be any other suitable tissue. So that's kind of what we do on the most basic level for supporting ancillary testing. And I'll let Leslie get to the how of it.
Yeah, the how of it. When we first started training for this role, we both were pretty eager to learn. And we were also really apprehensive because we had no checklist to follow. There was no outline of how we had to figure this stuff out. We had to be very self-directed. And a little step back, neither of us had ever heard of standard of care testing or next genome sequencing before we came to IU Health. It was a natural progression for us to want to learn more about that and familiarize ourselves with those. And working in this role, we've really, through experience, become familiar with standard of care testing and what that is, and the next genome or next next generation sequencing. How we achieved this was just on the job training. Neither of us had ever looked at histology or surgical resections before. And we were given the task to pick the best block for these ancillary tests or genomic testing and mark the tumor. And neither one of us were familiar with surgical resections or histology. So we could receive up to 20 requests a day for this kind of testing. And we spent a lot of time looking at surgical resections from different tumor types or surgical cases. And we would have guidance from more experienced techs to help us figure out what we were looking at, what we were looking for. And we also have a very detailed list that we use of all of the in-house testing and send out testing and what the requirements for those testing are, like how many cells do you need for a FISH test and how many cells do you need for a BRAF test? And also, you know, if we're going to send a block for genomic testing to Foundation, like what are their requirements? So we use that list and we're constantly updating that list just for reference. And we're very fortunate to work in a teaching hospital where our fellows and our pathologists have been willing to sit down with us and review cases with us, difficult things like DCIS, how to appreciate that desmoplastic response in colon cancers, prostate, that different grades of prostate cancer, because we always need to send the highest grade of prostate cancer for testing. And we deal with a lot of breast cancer cases, and we really need to be able to differentiate DCIS from invasive cancer. And that's been a struggle, but with these reviews with the pathologists and our fellows, their direction has been invaluable, and it's really allowed us to be able to be successful in this role. Some limitations that we do have are our primary brain malignancies. They're pretty tricky. So if we have to look at those, most times we get our neuropathologist to review it and help us with those. Another limitation that we run into is companion diagnostics. I feel like the PD-L1 is always changing. You know, we're no longer doing SP142 on triple negative breast. We're no longer doing any PD-L1 testing on urothelial carcinomas. So sometimes we know this before the oncologist. Sometimes we don't know this until way down the road. So that's been a challenge, trying to keep all those the companion diagnostic updates. But there's definitely a learning curve to this. And I feel like our experience just looking at it has made us more confident in what we're doing. We joke that the very first time we both looked at surgical resections, we both thought a benign lymph node in a resection was malignant because the germinal centers, they look similar in FNA and a resection once you know that you're looking at a germinal center. But I think we both were like, oh my God, it's positive.
There's a nest of adeno in the middle of this.
It's just a germinal center. So there's a learning curve that we had both had to go through. But we were both very curious and excited to learn about the histology and get more familiar with, you know, the things we were looking at. And circling back to what Melissa said, if the cytotechs were not filling this role and picking the best tissue for these tests, the pathologists would have to be doing it. And, you know, we can fill that gap for them. We can do that. And then a step further into that role is the precision genomics role that we fill. In 2017, Cytotech started supporting precision genomics. They're a group at Simon Cancer Center of oncologists, pharmacists, and nurses, and they use genomic sequencing to help guide their treatment for late-stage cancer patients. We currently have 6 cytotechs that rotate through this position, and 2 of us are full-time every day. Before we started supporting precision genomics, the unit secretaries would get a request for genomic sequencing, and pathology would fulfill the request without triaging. And our failure rate of these genomic platforms was 28%. But once the cytotechs got involved, our failure rate has went down to 4.9%. So it just shows that by us getting involved and really, like Jessica said, reviewing everything, it's made the failure rate go down. And this role is like a project management role for us. We spend a lot of time problem solving and communicating with the PG nurses. Our goal, we're given a patient and we want to send the best tissue possible for genomic sequencing. We currently have about 65 patients in our precision genomics clinic, and that number's changing. It just kind of depends how long it takes us to get the patient from referral to their block out to sequencing. It could take a couple weeks. But we're given a patient the goals of sequencing. We review all their historical materials on each patient independently. We review all their pathology in-house. We request and review all of their pathology at outside hospitals if it's relevant. Then once we have all the tissue that we have, together. We pick the best block
Connolly, or is it?
from the best specimen. Sometimes we send a MET, sometimes we use the primary site. It just depends on how good the
Yeah,
specimen
and he
is.
knows that we combine it with the specimen.
And we determine which genomic platform would be the best for each specimen too, because we use 2 different platforms, and the platforms we use have different thresholds. One of the platforms uses whole exome sequencing and the other one does not. So learning the thresholds of each sequencing platform, it's been a big learning curve. We're constantly collaborating with each other, learning from our failures, and sharing what's successful at each platform.
Just ask him if he can order.
We're
We're not going to do anything with that search.
Someone's not muted.
With that search path order. Ask him if he can order another cytology.
Is unmuted. If you don't, thank you.
And we also are in constant communication with the pathologists at the different platforms. We often send them images of our H&Es, and we discuss cases that we think are borderline. There's a lot of limitations that we have to work through with these platforms based on the age of the specimen, necrosis, mucin, competing lymphocytes, benign nuclei, decaled specimens. There's all these things that go into picking which block would be best at which platform. And then we also always ensure that companion diagnostics are ordered appropriately. Sometimes the ordering oncologist wants a PD-L1 ordered upfront in-house because they want to start treatment immediately. Other times we just order the PD-L1 at the genomic platform. And then also confirmatory IHC, we make sure those are ordered appropriately. After sequencing, if a patient has an ERB mutation, we order a confirmatory HER2 IHC. So we always make sure that all of those things are in line with each patient. So.
So obviously all of this takes a lot of collaboration and kind of continuous sort of communication with all the different entities. I do want to expand a little bit on what Leslie was saying about selecting the block and the service that we provide without, with what traditionally happens without having tissue triage. So all of our techs learn to select an adequate block for genomic sequencing, which includes a consideration of, like Leslie said, metastasis, competing benign tissue, necrosis, mucin, et cetera. But another step that we provide here at PG is we actually also then evaluate the cassette. So we're able to see if the tissue is viable in a cassette or if it's been depleted, like you see in this block here on the left. And if that's the case, then we can explore other options right up front. And so, as Leslie said, our failure rate has gone from 28% to under 5%. And this is a huge reason for that. So just to kind of quickly take you through how that, to illustrate how that really works, in a traditional sense, the pathologist chooses a block, it gets shipped, it's not sufficient, that comes back to us, the pathologist would have to re-review the case, an alternate block would get shipped, and then finally testing can occur. So we're talking weeks of time here that we're able to eliminate just by reviewing that tissue, the actual physical tissue right up front. And then also if the block does fail or is exhausted, we can look into sending a cell transfer, which I'll talk about here in a minute a little bit more. But basically, we have one of our platforms accepts cytology smears to do sequencing on, which can save the patient a totally new biopsy, or potentially the patient would miss out on getting targeted treatment altogether. So it's a big service that we provide in addition to just having a faster turnaround time. So Leslie mentioned earlier how we kind of integrate the limitations and benefits of our different platforms with what tissue we actually have and what the goal is for sequencing. So this just kind of highlights that. But I did want to take a moment here to touch upon how we've actually influenced what these limitations are for these platforms. We've had just extensive collaboration with them regarding our cell blocks. There's this kind of prevalent view that cell blocks are just not robust enough for sequencing. And so we've spent a lot of time sending them examples and samples of our cell blocks to show them that we actually have really good success.
Convincing them to try them.
Just convincing them to even try our cell blocks. So, and we, then they've seen that, yes, we have good success with our cell blocks. And so we've pushed their thresholds quite a bit, not just in cell blocks, but just in general. We've kind of found that we have such an extensive knowledge base that we actually know better than they do what will be successful in sequencing. And even a step further than this, I mentioned cell transfers on the last slide. Melissa was actually able to take our success with cell transfers and molecular testing here in the lab and translate that into, creating this whole new platform for sequencing where they will sequence off a cell transfer from a cytology slide. So it's been really fun and exciting to kind of be part of this collaborative effort with the platforms to help them advance as we advance. So the collaboration with the sequencing platforms is really just a drop in the bucket. We collaborate with all of these entities that you see here. And liaise with them. And it can be difficult because we're dealing with, the standard of care operators as well as the precision people. So it just takes a lot of communication. We're kind of at the center of this web here, and we put all the pieces together. And I'm going to walk you through an example that was an actual case. I want you to keep in mind, as you see the gaps that we're bridging, how it would be really impossible for a pathologist to incorporate because of their time constraints. So for this patient, we'll call her patient A. She had a lung mass and nothing really else of note on imaging except this PET-positive subcarinal lymph node. And she was a patient at an outside facility. So they cored it and it was malignant. They stained it. The patient was referred to our PG clinic at this point. And clinically, this is considered a lung adeno, but the staining profile was this. So it actually was favored to be from a pancreaticobiliary primary. Okay, so what next? Now, we received the case. We reach out to the outside facility because we need to do a consult on the case and see what the tissue looks like. And we received the case and the block's exhausted. It's totally done. So then our patient gets scheduled for an EBIS for that positive, PET positive node at our facility. So we reach out to radiology, like Leslie mentioned. We deal with them to make sure that we can, have a tech present at collection and that we get what we need from them. So we were able to get the biopsy. We also communicate with our pathologists and let them know that sequencing is wanted. So they need to conserve tissue as much as possible. So they did run stains on it. And again, it was staining like a pancreaticobiliary. So we did not order a standard of care panel up front for a lung adeno. However, because clinically they still thought it was a lung adeno, the ordering oncologist really wanted to do that lung panel and PD-L1. So we contacted the treating oncologist and let them know that we were sending this for sequencing. And so a lot of those answers would come in a few weeks with the sequencing platform, like the BRAF and EGFR and all of that. But, it would be a few weeks. The oncologist still wanted to move forward. So the problem was we had just enough in the block to send for whole exome sequencing. We definitely did not have enough for all of those things. So our next step would be, we would need to alert the PG team in case we were not able to triage or for triaging in case we were not able to run all the tests and so that they could, be in the loop on how to triage the tissue. But we actually were able to then go to our prep lab. We were able to run the lung panel on our cell transfers, cytology smears, run the PD-L1 over a negative immunostain that we already had. So then we were able to keep our block and send it on for genomic sequencing. And so the final part was we contacted the genomic sequencing platform and let their pathologist kind of be aware that we would be sending a CK7 slide with it because it was really necrotic and the tumor was really spread out. And we found that if we keep them in the loop and send an IHC stain like this, that they're much more likely to push through and try a specimen that maybe originally they would be like, oh, I don't think this is going to work. We've had a lot more success with that. So that was a big, long example and a lot. So, but I just, wanted to give you a feel for the kind of troubleshooting and problem solving that we deal with every case on a daily basis. And we have multiple cases every day. So I always say I feel kind of like a plate spinner where you're like spinning the plate over here with this case, and then something's happening with this case, and then you contact this person and it gets crazy. And so that was definitely like one of the challenges moving into this level of a role is just
all the different patients in the PG clinic, and they're at different levels of what we're doing with each patient.
And different parts of the process. But so that is a good example for kind of our highest level. And so we're going to switch gears now and go to the other point that I mentioned back a while ago, the other way that we really kind of do a more advanced role. And it's not quite as advanced. It's something that a lot of techs all over the country are doing, but we're going to kind of touch on, the level that we really take it to. So the rapid assessment. So I'm going to turn it over to Leslie here.
Okay. So like Jessica said, we're all capable of doing the rapid assessment. Out of the 18 IU Health hospitals, we offer cytology service at 10 of those. And our cytotechnologists are often doing the rapid assessments without a pathologist at least 8 of these hospitals. And we find that the expectation is more than just, is it adequate? Like a few scenarios that we encounter every day are, pancreas biopsies. The proceduralist wants to know, if it's positive because they're going to put in a metal stent instead of a plastic stent, or we might be on a lung biopsy and it's a Friday afternoon and they're demanding to know, is this small cell or non-small cell because we want to start treatment today, this weekend, or possibly a thyroidectomy and surgery. They'll call us down because they found a lymph node they want to biopsy and they want to know, is the lymph node positive, because we're going to take it out. Now, while we're not going to give them a diagnosis, I feel like they expect some guidance from us, a little guidance as to what we're seeing will help them, guide them to what they're going to do next. And I feel like we've been able to get to this level of training to where we can confidently give them this guidance and help fill the gap when the pathologist is not able to be on site with us or attend a rapid assessment. So that's one way we've kind of been able to elevate our rapid assessment skills. Another thing is we are always thinking ahead. We are always thinking about future testing because NGS testing is always what seems to be what the oncologists are wanting. We huddle every morning and we discuss all of our patients in the morning for every procedure that we're going to go on. And we do extensive digging into their charts. Whereas the pathologists don't have time to go dig in each patient's charts before the procedure, oftentimes we'll find a little nugget of information that the oncologist wants, genomic testing.
Yeah, like in a phone note or something random.
Phone note that they want that. So we take that information and we go into the procedure knowing that we need to collect enough material for genomic testing. And we often are the only ones, like the proceduralists are not aware of this. So we communicate that to the proceduralist, and the proceduralists have looked at us as kind of a subject matter expert, I feel, for guidance on to how to collect for this stuff. We always are thinking critically through these things, like a lung biopsy. It's always like we need to have really good smears so we can do lung molecular panel on our smears, and then we need to have a cell block or cores for genomic testing. Or if they're a PG patient, we collect a certain way up front for that. And we always want to make sure that I think mainly we just don't want the patient to have to come back and get another biopsy. If we can just think ahead a little bit and do a little digging, a little research on what really the expectation of this biopsy is, it's more than just getting them, it's cancer, there's more that goes into it. And I feel like we have really taken that a step above. And we have a really good rapport with our proceduralists, and I think they can really trust us. And we circle back with them, and we are able to communicate with them, like, hey, this is what we need, this is what works, and I feel like that's really gained some trust with them. And like I said, we do an extensive review of the patient's charts every day before the procedures, so we know what we're getting into. And then another thing that we, every morning we have access to the pathologist QC conference, and we can see that virtually thanks to COVID.
Yeah,
so used
everyone's
to doing
Zoom
everything
expert
by Zoom, but we are able to learn a lot about standard of care, different IHCs, just a lot of morphology just by watching the pathologists communicate with each other about different cases. And then we also collaborate amongst ourselves as the cytotechs and have our own little QC conference where we look at interesting cases, difficult cases, and we talk about just collection do's and don'ts, things we've done well, things we shouldn't have, should have done better. And just the thought process of how we learn from each other a lot. So.
Okay, so hopefully we've kind of demonstrated here that there is a current real need for cytotechs to move into these roles that we've detailed, and kind of giving you a day-to-day view of what it's like for us. On the job training and plain old experience are just really key for us to get here. We have about 20 techs, and they're all different levels of experience and different backgrounds, but we have successfully trained all of them to do at least some of these advanced roles. And like Leslie here, who was coming from 10 years of just PAPS, and within 2 years is at our highest level. We are able to do it. Cytotechs can do these roles. We have the tools and we're there. Certainly there are techs out there who are happy with their traditional roles and wouldn't want to move into these roles. But like Melissa said, I think there's a large cohort of us who are just really driven by this opportunity and ability to be an integral member in the patient's care team, and just are excited to be constantly learning new things and developing our roles. So what are the roadblocks to transitioning techs to these roles? I can tell you from coming from another hospital, I worked at a couple different other hospitals in a more traditional role. And, I don't think that it's training that's the roadblock. I think it's more just the bureaucracy that's inherent in the laboratory system, as well as just the natural human aversion to change. I mean, departure from the status quo is scary. Especially in a field like ours that's so entrenched in validations and protocols, and it's just difficult to get the wheels moving on any sort of change. But thankfully we have Melissa, who when presented with the challenge, like she mentioned, of pathologist shortage and employee development, was able to really think outside the box and open the eyes of our administrators and pathologists to the fact that there's a real opportunity here for us right now. So I think, like I said, we have the tools for this. We don't need to be worrying about our profession dying and HPV taking away our jobs. It's more, the shift just needs to focus to affecting a perception change at the administrative level of what the scope of our duties can really encompass. And we will get there. So thank you.
Yeah, thank you.
Thank you for this amazing presentation, and I'm very impressed with the spectrum of roles that you have already implemented at your institution, and the fact that you're able to be recognized for the roles that you're performing. And I think your presentation answers a lot of the questions in the chat. I'm maybe gonna answer one earlier just to show you that not everybody is as advanced into implementing these roles as your institution is. So there is a question if we do allow interpretation of immunohistochemical stains and breast biomarkers such as ERPR and HER2. And I would tell that at our institution, we do not, but it's not that we don't allow, we just do not perform it. But then do I think our cytotechnologists will be able to? Absolutely. I think it would be a skill that can be picked up in no time. Is it useful for the breast service? Tremendously. So, but I think we're a little bit not there in terms of creating an environment in which that is defined as a role that can be taken over by a cytotechnologist. The same for selection of tissues for complex ancillary testing. And actually, I'm very impressed how you're able to have the cytotechnologist at the center of interacting with all the clinicians and making all this relatively clinical and subtle decisions. So it's really, really good. There is a question that asks, is it legal for a cytotech to give a diagnostic preliminary interpretation rather than an adequacy during the rapid on-site? What do you think?
The question was, is it legal?
Yes.
Well, that's why we said they expect certain things and we give them guidance.
Yeah, we are
never give
definitely
them a diagnosis.
we are definitely not telling them a diagnosis, but we can just, to the best of our abilities, try to give them guidance on what we're seeing and, you know, kind of go from there.
And part of that is the idea that, let's say you're approaching a needle and you think that they might be trending towards a metastatic breast cancer, and maybe that's unexpected. Well, that's taking a step back with the radiologist to say, you know, we want to account for this and this scenario. You're not necessarily coming right out and saying, we think this is breast cancer, but we're thinking ahead enough to know that we're covering all the bases so that that patient doesn't have to come back. We're not talking about a legality thing here. We're talking about, how do you think through critically? How do you advocate for that patient?
But if I am to ask, and again, this kind of mirrors one of the questions submitted, but if you're talking about the instance in which you are kind of encouraged to give a preliminary on a small cell versus non-small cell carcinoma on a Friday that the clinician would like to pursue with treatment, how do you pursue that? Do you actually maybe favor something and then you have a pathologist confirm the diagnosis, or what is your routine?
Yeah, that's typically where you would rush it back to the lab and you would make sure that you were sitting down within 25, 30 minutes and everybody's holding, you know, on a Friday afternoon for that discussion. But yes, we have our pathologists step in there. But, you know, we have to at least make sure that they understand that now we're in that time crunch and that's how we're advocating for that patient.
Another question, based on your experience, since you have so many cytotechnologists that are going through this process, can you share which were some of the most, let's say, easily embraced active advanced roles, and some that were maybe the most feared, and maybe some that you may have some pushback from some of the cytotechnologists to take on as new roles?
So I know personally, I was terrified of selecting the two from the outset. You know, I'd never looked at histology specimens before, and like Leslie said, like looking at a lymph node where I'm like, this is malignant, and then finding out, no, it's a germinal center. It's like, oh, right, okay. So that was very, very scary for me, and it took a lot of just like Leslie said, self-directed training and review of cases, and it just comes with experience. Versus I felt like, you know, I think it's a more natural evolution for a cytotech to do a rapid assessment on their own. That wasn't quite as scary for me. I don't know.
Right. And well, doing the rapid itself was scary just because I had never
Because you hadn't done it before, right?
But looking at the tissue was very intimidating because I didn't know, like we talked about. But our fellow spent a lot of time with us at a scope, showing us different entities and helping us recognize certain, that was really, really, really
Well,
helpful.
it was really helpful. And that's where we learned about the whole desmoplastic reaction in colon cancer, which I was also like, oh, I didn't know that. And so we've been able to, because this is in this whole scheme of things relatively new. So we've been able to kind of take those instances and come up with a more comprehensive training plan for our newer techs regarding tissue evaluation and whatnot. But definitely that was, one of the harder
Yeah, I
ones.
agree. That was.
And I think as far as the pathologist convincing them that we had these abilities, it would be things like Gleason score on prostate cancers, looking at DCIS versus invasive carcinoma on breast. Those are the things that we had to get over the hurdles to prove to them that, yeah, we're okay here still. And again, if it just feels like it's too tough, we have the support of the pathologist. We'll sit down with them, but they have enough trust in us, and our genomic partners have enough trust in us that they're very impressed with what we've been able to come up. And they have shared that with a lot of different genomic platforms to say, hey, their triage process is really tight. So that was scary getting the buy-in from them, but also on the business side of things, once we showed them what value we could add to the precision program, they actually picked up the salary of 2 of our cytotechs. So, as time goes on and you need to do more collaborative roles and share positions in a hospital system, this is another way to do it, is to show that there are other services that would gain value from that expense.
Thank you.
Mhm.
And then there is a more direct question, which you may or may not be able to answer, but I'm going to read it. It says, can you give the salary range for a Cytotech 3 who is performing these complex tasks?
I could if you emailed me.
Okay, so
we can share our email addresses with the group if there is interest in continuing this discussion in any way.
And actually, I have another question, because I think as you're portraying different level of skills and the participation in training from even like probably senior residents, fellows, in addition to pathologists, and just the fact that I think currently the advanced practitioner activities are largely confined to academic institutions. Can you please expand what could be your vision of one, maybe what is the need, and then how do you see the implementation of these roles in settings such as private practice or community hospital settings?
Okay, so I think that there's still an opportunity for these, maybe not necessarily the genomic selection, but there's always an opportunity for cytotechnologists to take a look at your outputs and your outcomes for your patients. And let's say you're working in a community hospital practice and you see that there's a consistent problem with maybe people aren't submitting ischemic times or things like that. Any of the things that make us better labs are an opportunity for cytotechs to learn to interact with other people in the healthcare community and to figure out how to work collaboratively together for the benefit of your patients. And sometimes it's stepping outside the box. Sometimes it's not pathology. I have stepped into a giant role with what is the delivery of reports in the EMR system. I mean, there are lots of things like that. And here again, cytotechs are well poised to do something like that because they understand that crossroads between what's the clinical lab need, what does the anatomic lab need, and what does the patient and the physician need on the other end. If you always ask the question, what can I do to benefit the patient? It doesn't matter where you work, sky's the limit.
Then maybe one last question, as probably many other practices are going to look at your model and try to implement and be successful at implementing these expanded roles. What are some of the most important, like for well-defined ways in which pathologists can help you along the way.
Give us your trust. That's a big thing right there.
Pardon?
You know, give us the confidence to know that you realize that we're doing this for your benefit.
Yeah, we cannot hear you. So hopefully the team from Indiana University can log back in. And actually, this should conclude our session. We're going to provide all our contact information, and we're welcome to answer any future questions you may have. Thank you so much. And again, thank you for the team at Indiana University for this eye-opening presentation. Bye, everybody.